Good morning, everyone, and welcome to a very exciting panel that we have today. We're going to be talking about barriers and challenges in newborn screening. I'm Jeff Lord, and we're going to be talking about a process here. What sparked this is a new process for the Dash Alliance called Rare 72, which will be a virtual hackathon. And this is kind of the beginning of just laying some planks on the floor, if you will, about what we want to talk about in that arena. Joining us today for this conversation is Chris Porter, and Chris is with Trevere Therapeutics, and also Megan Perry, and Megan is with Orchard Therapeutics. So I'll turn this over to you all and give you a brief background of you, and then I'll go last and tell a little bit about Eden and I and about the Dash Alliance. So Megan, ladies first, please tell us about yourself and what you do for Orchard.
Thanks, Jeff. Thanks for having us. And thanks to you and Eden for putting on this event. As you said, I'm Megan Perry. I support U.S. Public Affairs at Orchard Therapeutics. And at Orchard, we are so supportive of, working to advocate for the continuation and modernization of the newborn screening system and making sure that all the, kiddos born have a fair shot at a newborn screen to help them get medical diagnosis and subsequent care. So thank you for having us today and including us in the conversation.
Well, thank you for being here. We really appreciate you joining. Chris, tell us a little bit about yourself and Trevere.
Sure. Thank you for that, Jeff. And again, I want to echo what Megan just said. Thanks to you and Eden for putting this on. And it's a pleasure to spend time with you all today. I'm with Trevere Therapeutics. We're a small rare disease company based in San Diego. I'm the Vice President of Government Affairs and Policy. And I'm a rare patient myself. So about 16 years ago, I got a full cadaveric liver transplant for a rare liver disease. So what I try to bring to work, and what so many of our employees do, we're just a little company. What we bring is that experience that either we carry with rare disease or a loved one or a friend that lived with rare disease. So we really look forward to the panel today. When it comes to newborn screening, we're about one really important thing, which is shortening the diagnostic Odyssey. My own Odyssey lasted about 3 years. In a lot of ways, I was lucky because there was essentially a treatment available. There was no therapeutics available, but I was able to get that liver transplant. So anything we can do to shorten that journey, is something that's going to be important to us. And that's what we hope to talk about today, and how we can all work together to shorten the diagnostic Odyssey through newborn screening.
Well, thank you, Chris. And it's great to have you. So my name is Jeff Lord, and my wife is Eden Lord, and Eden founded what was back in 2009, actually, right after our daughter was born. We started working on what to do, and she founded My City Med. And since then, we have grown and become what is today is the Dash Alliance. And the Dash Alliance is really about connecting, making those connections. We do a variety of things, but we really just want to help rare patients find the resources. And, we picked newborn screening as a process for this new initiative on the Rare 72 virtual hackathons, because we see the need, we see what's happening out there. And this is a big nut to crack. I mean, when you start looking at everything, and because of the way that it's designed, and, we're going to be focusing obviously on the United States today. We've had a really big showing from UK and how that process is done in another country. So this is really going to be focused more on about the United States and our policies and our processes with it. But we want to thank you both. Eden and I thank you so much for joining us today. Megan, I want to start with a question for you. You work with patients, directly with the patients a lot. How are the patients impacted from a lack of standardization state to state? Because if we look at the RUS, and which we're glad we have some kind of starting point with it, and we have some guidelines, but then it's kind of like, well, this is the recommended guidelines, but state to state, your state might do it, my state doesn't. And how does that impact the patient? And that's really what we're about trying to solve here is what to do.
Yeah, it's such a good question. And, I think it really speaks to the power of the advocacy in the community, right? That it's really the burden on the patient community to go around at the federal level and advocate for inclusion of a new condition, not to mention the extensive process of filing a RESP nomination and managing the pilot process, and then going through every state and trying to advocate as well. And I'm sure you know as well as everyone that, when you first submit a RESP nomination to the time it maybe is approved can be 6 years. And then I think it can take up to another 10 to get every state with a screen on the panel. So I think it really speaks to the power of the advocacy community. But wouldn't it be so wonderful, to Chris's point earlier, if we could sort of compress that timeline and make things a bit more efficient of a system, so there's not such a heavy burden on the community who's already dealing with these really hard and sometimes devastating diseases to have to go around and do so much yeoman's work in every state.
So expanding on that just a little bit, as I sit here and I think about it, because we have tried to do things in other arenas with patient administered medications and carrying your medication on you and doing it, and that is also another state by state thing.
Yeah.
You do have this, do you, and it's kind of the chicken and the egg thing sometimes, but do we look at, do we attack both fronts at the same time, where we attack the federal side? I don't want to say attack, that's bad terminology, but do we address the federal and the state at the same time and try to align those initiatives to try to shorten that? Because with the federal mandate, like you said, it may be 6 years, but do we work stateside hard and find that in there to try to get that through on newborn screening before the federal? What do you think? Are we wasting our time one place or the other? We want to be the most efficient possible to try to shorten this, and what do we do?
I mean, I personally will also point to a study that was recently published in JAMA Network Open that Chris was involved in, and Every Life Foundation and Biomarin and Sarepta as well, that really talks about exactly what you're saying, some solutions for modernization. And one of the big buckets is really better alignment at the state and federal level to be sure that, this isn't such a problem anymore. So I guess my instinctive reaction would be to say you have to kind of work both ends of the system at the same time right now, while trying to also, resolve some of the challenges of the system that we're working within.
So Chris, that flips right over to you, because I had that down, is that I knew you were part of that study on modernization. What is your take on? Can you speak to that and the kind of the study and that alignment and some of the challenges that you identified from that?
Yeah, sure. Happy to, Jeff. And you started this off by saying that it's a big problem, and it is a big problem. But it's also, it really starts with the fact that newborn screening is a system, and it's largely invisible to most people. So it's not just, one diagnostic measure, it's everything, starting from the time that baby is born, to the people in the hospital, to the newborn screening labs that do it, to the follow-up care. So the system itself has so many different pieces. And, to what Megan said, a lot of the pieces are not connected. And to your key question about federal kind of state partnership, the current system is just like that. And this is part of the study, is that it says that, this is a loosely connected system. So there's not overarching goals, and there's not a lot of connectivity. And, I don't want to be critical and not critical at all of the people that are involved in the current system, because these are great people doing really hard work under very difficult circumstances, but there's no connection between them all. And there's a lot of political pressure that happens at the state level, where if you're a new condition and you want to get that if you are a family has a new rare disease and you want to get that implemented, you're really subject to whatever the politics are of that particular state in that particular year. So that's why you're seeing, so in one sense, this is a huge public health success, right? It's universal. Everybody gets it. It's so universal. A lot of people don't even know it exists. You know, you only hear about it if something bad happens. But on the other hand, when you have to go in and try to implement it, looking at the current system, which really was set up about 14 years ago, there's only been 6 new conditions approved. And of those 6 conditions, 4 of them are not being implemented in every single state. So I have to believe we can do better. And maybe the big approach, you know, and this is just one idea, this is not related to the study, but it kind of speaks to that key federal state question, is to have a more coordinated approach federally, use the resources of the federal government to coordinate things, and then provide more resources and different types of resources to the states so that they can build on the infrastructure that they have. Because this is the threat, is that if we don't try to fix it from a public health perspective sooner rather than later, you're going to go into a 2-tier system where people who have the money or live in the right places are going to have their babies get much more screening, and their kids will have a better chance of living and having a healthy life than people who do not. So there's really a health equity threat here if we don't try to solve this, or at least start to try to tackle it right now. And that's where, you know, the study helped to codify that everybody throughout that big system, you know, wants change. So, you know, the purpose of it really is just to kick off that discussion. So I felt like I rambled there for a little while, but it is, it's a big issue. And you know, the purpose of the study really is to try to kick off that dialogue among all the stakeholders, but it's not going to happen overnight.
No, it isn't. And so, you know, those resources, you make an interesting point that of the 6 that have been identified at the federal level and added, there's what, only 4 you said that were added at the state level, I think is what you said.
As of today, 4 of them are not being implemented in all 50.
Okay, so 4 of them are not. Is that because of lack of funding resources? It costs too much money? Were we able to identify as to, because I see that this being a problem, you know, as a parent, you know, I am where I am. I'm in North Carolina. So when I look at North Carolina's newborn screening, what do I see missing that you know, that's there? But to the south, I mean, South Carolina, totally different ball. But do you see the reason that those aren't implemented? Is it political? Is it financial? Is it the lack of, because some of these do take some specialized testing in order to screen, you know,
Right.
for it. So is it that, you know, or did the study go into identifying, because I have to ask that question, why are those 4 that were worked so hard for to get at the federal level not being implemented at the state level? Why doesn't the state just automatically adopt them, you know, with it?
It's a key question, Jeff. And in fact, in 2019, there was a study called the New Steps study that was commissioned actually by HRSA, that identified that lack of state resources is the #1 barrier. And if you talk to, you know, we do a lot of work with folks in the ALD and the Zellweger community, and when you talk to them, you know that from an advocate point of view, how frustrated they are because they put all the effort into getting, you know, the RUSP recommendation approved, but then, you know, then it's literally a state by state battle. So if you look at ALD, that was approved 6 years ago, here we are 6 years later, and it's only being done in half the states. So that means that babies are unnecessarily dying based on their zip codes. So we need to try to address that. But the you know, the state by state piece, and Megan can certainly add here, is really a function of the fact that there's no coordination between the federal programs. There's a little bit at HRSA, there's a little bit at CDC, there's a Hunter Kelly program at NIH, but there's no one saying this is what we want to do, you know, as a country in newborn screening. It's always been kind of pushed down to the states, and at a minimum, better coordination, which was part of the study, and I know Megan can speak to that, would certainly help go a long way towards trying to get a better system.
Megan, let's kick that back to you. From what Chris was just talking about there, with that as a state to state, that barrier that exists. Can you comment more on that?
Yeah, I think Chris said it really well, but when you look at the states, you have these public health labs doing this amazing work, right? They're doing a really good job and they're trying really hard to screen for all these conditions. But, as Chris said really well, there's a massive lack of resources sometimes, and adding a new condition can be very expensive. And then you're also at the mercy of the political process in the state. Every state, as we all know, is very different. Some require regulatory action to add a new condition. Some do it through the legislature. Some require processing through a newborn screening advisory committee, and some require a combination of all three of those things, not to mention the work, that goes into adding new screening machines to the lab and adding in the new staff that are necessary to do that. So it's a very long and, process, and funding is really critical for that, to the point that Chris was making earlier.
Yeah, and to add to that is that even with some of the screening processes today, I was kind of shocked at the number of false positives that we're getting from some of the newborn screenings that are happening. And I'm not sure, I hadn't had a chance to really read in depth of that. I don't know if that's because of the method that's being used, because, in the detection, I don't know. Did that come up in either of y'all's conversations with any resistance there with, false positives being an issue, that all of a sudden a child has a condition? Well, no, they really didn't. It was negative. They tested them again, and it just wasn't there.
Yeah, I mean, if you talk to folks on the front lines in the labs themselves, understandably, they're very concerned about the advent of genetic screening in how that plays into their role in a public health system, and it's a legitimate question. So usually, the blood, the heel stick that's done through a regular blood spot is one thing, but then if certain things are flagged, then a lot of times there'll be a second test, and a lot of times that's a genetic test, but that varies from state to state. So that science is evolving. We all acknowledge that. So trying to keep up with that and do that follow-up, a state can't let go of somebody till they've been diagnosed, or diagnosed as undiagnosed, and before they can close that particular file. So false positives are part of that life. So do we have a workforce that is available to help manage those kind of big questions? How will the labs do that? Should the labs, if you have a son that has a particular genetic disease, should that, you might also catch another member of the family, so where does the responsibility of the state begin and end? How do you handle that genetic cascade? These are big questions, and that's why the study is important, because there's got to be a way that if we think about it, we can start to get our handle on the kind of evolving genetic database and the technologies, and make sure that they're incorporated into any modern system, so that we don't unnecessarily lose patients, and we know how to deal with things like false positives and that critical follow-up care, where the state actually, or the newborn screening steps out, and the rare disease families providers step in.
Yeah, and we're in talking about that genetic screening process. I was actually had a conversation with a pediatrician yesterday on Diagnostic pediatrics, and we were talking about the two sides of that coin. Is also with it is that it's expensive to run full genetic panels. Two, if you run a full, if you have an indicator that there might be a need for it, but then you start running into other factors that determine is that should every child have a genetic panel done? And it said, well, you have a tendency, you have the gene that develops Alzheimer's. Well, I may not have to worry about that until I'm 60, 70. Do I even want to know about it? I mean, there are certain things there, and we're just not to the point of doing what we would call targeted gene, with it saying is that, do we do targeted gene screening where, we are looking for these things in a genetic thing, and then you run into the whole insurance, is that available to insurance companies up front? What happens to my data? Once that is, where does it go? So the ethical concerns behind the newborn screening are heavy too, with it. And, it's controversial. There's people who want to know, and there's people who don't want to know, with that. And I don't know, on the study, did you all address any of those ethical questions that come up about that process, as to where does that data reside, how public is that data made, and and a big one is with the insurance companies and providing quality care in a public health system.
I can say from the study perspective, we didn't delve too deeply into those issues, although the experts that were interviewed for the study are certainly, really well apprised and are able to consider those things as a part of their responses that were included in the study. And I think that's something that will certainly be, considered as we're going on into the next steps. And then I would just, I would say your comment on the coverage is also a really big one, right? Because if you look at the recent federal Cures 2.0 legislation, there's a demonstration project within that language that really looks at, the coverage, Medicaid coverage specifically for confirmatory genetic testing. So I think very similar to what you're talking about, you have an indicator, and then is that covered when you go to run the genetic test, either confirmatory post a newborn screening signal or because of a suspicion from a provider. So that coverage, particularly on the Medicaid level, is something that seems to be becoming a bigger and bigger point of conversation when there's a signal and a medical reason to have that happen.
Yeah. Chris, do you have anything you would like to add to that?
Yeah, so a lot of these issues kind of get conflated. When it comes to newborn screening, my short, shtick is that we can do this. There's only 4 million births in the US per year. So, a number of us has worked in other chronic diseases where there's like 30 million people with diabetes and, a kajikity jillion with heart disease. So in those states, we figure out, in those other disease states, we can figure out. So from a public health perspective, we already have a lot of assets on the ground. And there's 4 million births, and we're a big country. So, we can figure it out. The question, about genetic screening writ large, you've raised it, Jeff, is that there's a big educational challenge that as a country we're going to have to do as technology continues to get better. Matter of fact, just this week, Stanford broke Illumina's record and sequenced an entire gene, not just an exome, not just part of it, in 7 hours. And so that technology is going to continue to get better and better. And as it gets faster and cheaper, it's going to continue to grow as a potential tool. But we've got to do a lot of education about, for your average person, what does this information mean? How do I put that in kind of the box when I think about my own care or of loved ones' care? And do we have the workforce to be able to help and walk with people, as they go down that? But Megan mentioned the Cures legislation. There are places where we're already doing this and we're saving lives and money. So some of you may be familiar with, in California, we had Project Baby Bear, where they had 65. They were originally intended to do 65. They ended up doing over 100 babies that were in the NICU and undiagnosed. And instead of, doing what we're all familiar with in rare disease, right? Doctor tries something, you go down a hole, may or may not work. You go to the next hole, try that, go down that. I was misdiagnosed for 2 years myself. Use genetic screening in those critical moments in a targeted way. And they've proven in the Medicaid program, they can actually save money by doing undiagnosed babies that are in the NICU and using that genetic screening up front. So I think the point is to let's when it comes to newborn screening, let's talk about that advancing technologies and what are the roles are, how can we get the best system? And Megan can speak to this better than I, but there are, working in a rare disease drug company, we have a lot of visibility into what's coming down the pipeline in gene and cell therapies. And it's super duper exciting. I mean, in a lot of ways, people have no idea what's coming. And once these therapies get out there and are in part of the system, part of our healthcare system, people are there's going to be a lot of interest because they really hold the potential to transform lives. And that's those therapies are kind of joined with the need to modernize the newborn screening system, because otherwise people are all going to run to something that's not our current system, and that's going to be subject to it'll be too hard to try to retain the public health universality of the current system if we get too far down the road.
Yeah, and I think we're already seeing that on the genetic side. You're seeing, a lot of private labs that are doing, the genetics piece, and I do see what you're saying about that. If we're not careful, if we don't move, I want to say quickly, everything goes at a snail's pace, I think sometimes. but maybe we can increase the snail, a little bit there. Is that we could see this division of, hey, you get really, really good health care if you have able to afford really, really good insurance, or you have a lot of money that you can do this with. But it also sounds like, too, I think that we want newborn screening, but you do bring up the healthcare worker side of things, and that do we have the staff on the frontline workers? And that goes down a whole nother avenue of, we want this process in place, but we got to have people to run the tests. I mean, and you got to have geneticists, and there is a lack of. I know that there has been a lack of geneticists in the market and genetic counseling in the market from a public healthcare sector. And we work with another organization that actually has job fairs to try to recruit medical students into that particular field. Did the study, and do you all see this as being, even if we get this stuff going forward with newborn screening, addressing the challenges at the political level and adding it to the screening panels, you're still going to have to come up with, do the education programs to recruit people to get those frontline workers in place. Was any of that talked about in this process? And it kind of expands beyond, hey, the newborn screening process itself, but it's all part of it. And I don't care, Chris, you can. Do you have anything to talk about with that? Did the study address any of that or talk about it at all?
Well, and again, Megan's closer to kind of the gene and cell therapy stuff that's coming, which is. But the study did say, and ask, how are we going to deal with this, with the evolving science? And one of the solutions that was put on the table and tested is, how do we have, essentially some type of, and it's not that Megan might remember the word, but like the library, some type of clinical database that people can, that providers can refer to, as the VUs, the variants of unknown significance, evolve, because the genetic kind of diagnostic measures are constantly evolving. So there's got to be some way where there's, and that could be a role that the government could play, is to help facilitate that type of a database from a clinical standpoint, not from a, to store your genetic information, but for a tool for providers who are on the front line trying to do that, to walk with the patients through their diagnostic odyssey.
Megan, what's your input into this?
Yeah, I mean, I think it's so important. And, I think Chris was alluding to a bit to the cell and gene therapy pipeline coming, right? And MIT New Digs did a really lovely study to sort of look at what's coming down the pike. And, they're really anticipating that by 2030, there's going to be, potentially 60 new cell and gene therapy products undergoing regulatory review. And a lot of those are indications for pediatric onset rare diseases. And so you've got this huge wave, you're thinking 60, plus. I don't want to quote the number exactly because I don't have the study in front of me, but then you look at the juxtaposition of only 6 new disorders have been added to the RUS since 2006, and you have to wonder, like, how is this capacity system, going to handle this? And that better data piece that Chris is talking about, and the coordination in the states, I think is so important. And you mentioned something about the genetic testing at the state level as well, and I hope she won't mind my bringing her name into this, but a good friend of your organization, obviously, too, is Tara Britt in North Carolina. And I know she's been thinking a lot lately about how do you work to improve the enrollment and the interest of people working in those labs because of the pay grade and things like that. So I think there are a lot of amazing advocates at the state level starting to really recognize that as a really limiting factor and beginning to think about how to actually try and address some of that. And perhaps North Carolina will be a state where we see some progress there, thanks to her good work.
Yeah, and we've talked with Tara some. Eden actually talked with her just a few weeks ago about some of the initiatives that she is running with here in North Carolina. So we're going to. This is a big thing. Starting to get a few questions from the audience, and we're still about 25 minutes out with this. But I did have one other thing, and I think Chris, you bring up a good point too. About could there be a central repository just of information, that's updated and maintaining, and that's a whole challenge in and of itself. Is where does that reside? Who keeps it current? It's kind of like a certified wiki, where they're going out there, but instead of it being that people can post updates to, but they have to be vetted and they have to be done, which part of our process is that vetting process with it. But also though, that's from the doctor side. We see a lack of education, understanding, and I think genetic testing is there's people who are still afraid of genetic testing, and talking about, and not just genetic testing, but gene therapies, because if you identify some of these conditions through a genetic panel, there may be a targeted gene therapy that can help right off the bat. And all of them say the sooner you can start it, the better with that. But did you all see in the study of the lack of educational resources for patients, advocates, and even nonprofits? Because a lot of times we look at us, we're all running toward the same goal, but we're not always connected there either.
No, it's really a critical point. From the terms of the study really codified that everybody in the current newborn screening system, not just a drug company like us, everybody believes that there should be change. And then it put a couple solutions on the table and tested them. But there's going to be some other papers that are published that'll kind of explore some of these issues. But from a patient perspective, I remember getting diagnosed and going on to clinicaltrials.gov and not seeing anything for my condition at that particular time. So we have to always start with that piece in mind. That patient who's newly diagnosed and they're going through that difficult time, right, when you're trying to process everything. So that from a rare disease perspective, or a patient perspective, that has to be our starting point. From an industry perspective, I think, as a company, we can do better, and we're going to have to do better to work and partner with all the different organizations in this space to do the kind of things you're talking about, Jeff, to just expand education and let people, figure out how this information, which is really just medical information. It's another, like a blood test, it's just another piece of information to put into your, your own thinking with your care. But because it's so new and, I've been doing this for a while, I can't say I always understand all of it. There's lots of smart people who might, but I still have to take refreshers on it. So for anybody who's just kind of new to it, it's a lot to do. So, and that's the point of the study, is to start now so that we can have that dialogue. We certainly need to get more genetic counselors to begin with, but then it's got to go along with that patient piece, and that's going to take time. And there are good efforts that are out there that are starting that now. But I have a feeling, and I don't know what Megan thinks. I mean, I can see that we're a little behind now, and then I think the diagnostics are improving. We got thank God, these new novel therapies coming that are going to really transform lives. But I can feel us, it getting away from us if we don't, take some really bold actions sooner rather than later. We've been talking with folks too at both the White House and HHS to try to, and they're interested in this. They kind of see what's coming. So hopefully that they'll come on board too. But I'll pass it to Megan for the more on this.
Yeah, I mean, I will just agree with you on the complexity of the entire thing, and it becomes very confusing. I'm expecting my first child now, and I went through the prenatal genetic screening process, which is an entirely different conversation, right? And so there are all these different offerings and stages available to people, and I think it becomes very confusing and it's hard to navigate. So you're really right, Jeff. There probably should be some sort of central explainer on all these different facets, because it is getting away from us, and even those of us that are involved in this on a semi-regular basis because of our roles and our jobs, it's still incredibly confusing when presented with those options on a personal level as well. It's scary, and it's hard to make good decisions for yourself and your family.
Yeah, and it is, and you bring up a point about, because we're all in the mix, we're kind of all in this stream together and going with it, is that who becomes responsible for kind of that education piece on newborn screening? Who's going to take the lead? I mean, somebody said, well, I could volunteer, my organization could volunteer, but again, it takes resources, it takes money, it takes time to do that. So there's another factor of it with that education piece. I'm going to ask you too a kind of a guided question here, and then we're going to open it up for some questions. But Megan, I'll start with you. If you had to pick something to say that would bolster newborn screening support, what would be a good first step that, as organizations, patient advocates, and even industry, that we could take together? What do you think is the first big thing that if we're going to pick a target to shoot at and go for, what would it be?
Gosh, you really hit me with a hard one, and let me go first. Thank you. Just
ladies first.
We're gonna start doing gentlemen first. I mean, I really think that there is a fundamental, need to really educate decision makers on the fact that newborn screening, when implemented consistently, prevents, injury and death that is entirely avoidable for these kiddos. If there is a therapeutic intervention or a diet or whatever it happens to be that can help these families, it seems like something we should really be focusing a huge amount of attention on, to ensure that as soon as that is available, these kids are getting screened for these conditions. And I think sometimes, though, that can be really lost in the education process. People don't always necessarily tie the two things together, because there's a lot of bureaucracy and politics that go along with this. So I think really, making sure we're always reinforcing the life-saving potential of newborn screening is really important to motivating people to actually make some change. And that's my off-the-cuff answer. Maybe I'll think of something better for you when I have a second to sit with.
Yeah, put you on the spot, Chris, what do you think is that should be the probably the number one goal, or the number one action to try to work toward?
Yeah, Off the cuff was pretty good, Megan, because I think the bureaucracy of the current system is incredibly, it's a huge roadblock, which ends up in, unfortunately, preventable deaths and disability. So, trying to take that out would be an important thing. If I had to do it, I mean, I would say it really has to start, at the top. Only the government really has kind of the resources and the wherewithal to try to, move the ship on this. And, as I mentioned, the law currently is so piecemeal that it's not there, it's barely able to do what it needs to do now, and certainly is not, built for modernization. But there's also, and this is my thing, people have heard me say this, I say it all the time, two things can be true at the same time. It is true that, the current law compared to 20 years ago is an unmitigated success. And all our public health workforce has made that happen. It's eons better than it used to be. But if you take those same, 14 years and you look out 14 years, that's where you go, yikes, because, we can see what's coming. So we really need to start with, really smart people in this country who can, think about these things and are on the front lines to get together and try to figure out how do we get to that system in a way that works better for that rare disease patient who just got diagnosed. How does it work better for the family who, gets some type of, results that are, maybe not what they expected. We can start now to start thinking about those big pictures. Otherwise, we're going to have an even, it's not just going to be bureaucracy that we're concerned about and long delays. It's going to be a bigger mess from a public health perspective.
I think it's great. Thank you both for those comments on this. We're going to open it up, and I'm going to encourage, the gallery has they can unmute and turn on their camera. So Dean, I know you posted in there, you had a couple of thoughts, and ask away or share your thoughts, your ideas. This is kind of an open forum here.
Well, thank you. I'm Dean Sir with MLD Foundation, a co-founder back in 2001. We and a rare disease dad caring for it's morning here on the West Coast, so I may jump away here quickly. So I'm going to throw some things out that I just want to put in for consideration. First off, just observations, great conversation, so many things have been touched on here. But the goal, I think, Jeff, you're trying to get to is how do we turn this into action and next steps and baby steps and big steps and so on. There is a lot of momentum and a lot of interest in the newborn screening space. There have been various organizations and groups doing a lot of work on this for a long time. Education, Baby's First Test, and the Genetic Alliance team, particularly in the policy space, Every Life, working on their community congress and their newborn screening working group, and their RUSP alignment legislation, which I think is up to 5 states now, with 4 more coming this year, that will tie the federal activities to the state activities, at least in terms of please consider this disorder. March of Dimes, the advisory committee has matured a lot and is now looking at the future as well. So there's a lot of activity, and I'm excited about how the Rare 72 project can contribute to that. I would argue that the goal here is not good newborn screening. The goal is getting access to therapies for the patients that need it as soon as possible. And newborn screening is an obvious choice because it's universal and it's a system that exists that we want to build on. But likewise, it's a tool in that process, and simply getting the diagnostics and having an approved therapy is not adequate. We need to have access and reimbursement. These states that are identifying these children, whether they say so or not, some of them are concerned because roughly half of the children out there are on Medicaid or end up on Medicaid. So the state ends up paying for these therapies. So we need to be looking beyond, is it a $2 blood spot test or a $50 or $25 genomic test? It could be hundreds of thousands or millions of dollars for some of these therapies. Newborn screening is state public health, so it does not stand alone. So we have all of the other things wrapped into state public health in terms of both the ethics of that and the process and what their role is. And much of what we're asking for newborn screening actually is pushing the boundaries of public health. So it's not the newborn screening lab and their directors that are pushing back. It's really the public health system that they work inside of. Policy and resources are the key things that they need, as well as just general support. But resources is not just dollars. It can be space, it can be people, it can be salaries, which again is dollars, but it really is the range of salaries, because they get good people that come in and go away. And two other points. Sorry, Jeff, I got off. Two more I wrote down. A comment about false positives. You talked about that for a moment. More important than false positives is false negatives. Newborn screening wants 0 false negatives. Remember that newborn screening diagnostic tool, but it is not necessarily a diagnostic confirmation. It's the precursor before you call in that baby and that family and then go get a formal diagnostic confirmation. So maybe I'm crossing on the ethics side here, but we want to err on the side of as few false positives as possible, but a false positive is so much better than a false negative. And then I just wanted to throw in one ethics issue, because you touched on that as well. One of the challenges that the more recent disorders are identifying, and will be the case with metachromatic leukodystrophy, is the identification of later onset disorders or later onset forms of the disease. And that's an ethics issue. It's a tracking issue. It's a monitoring issue. It's a privacy issue. It's so many things. So you can't solve, Rare 72 won't solve all these problems, but I'm on board to take the journey and start tackling them, one at a time. So maybe, maybe however many, years from now, we might have, dents not only in 1 or 2 of these, but 10 or 15 of these, but we won't be done for a long time. But thank you for this forum and the opportunity to participate.
All right, thank you, Dean. I think that part of, when we were addressing some of this, we do see a bigger picture, and we can give example after example. Is that so? You have identified the problem, and then we do have to have the resources to treat the problem. And that resource, I mean, we experienced that with Cambria, is that we didn't have the local resources to, even in Kansas City proper. Sometimes we had to go as far as Houston, Texas, or initially it was NIH. So we traveled to Bethesda, with it. So I see, I see that as being, yes, part of the challenge is that, you get the screening in, and then what? We've identified it, and then what to do with it. So, Chris, do you have any thoughts on anything that Dean said there about, toward the process? I don't want to get too far, out of, the newborn screening isn't, but it is a several step thing that we have to think about, not just turning on the newborn screening and saying, hey, we've got this on the panel, but then what?
Yeah, no, I really appreciated Dean's comments and thank him for all the work that he's done in the rare community over the years. The one thing he mentioned, which I think is really, or one of the many things, is that the diagnostics that happen after newborn screening. So, the onset of disease, that things that present, when kids are younger, when they're toddlers, or maybe even in tweens, there's an incredible amount of activity going on that. And we actually just held a conference, or like a salon dinner with a number of major leaders across the healthcare system to address that, because, there's so many groups out there now that are offering genetic testing, but there's nobody connecting all the dots. Everybody is doing what they can in their silos. So as a result, people are not getting the referral to care, and they're not getting the treatment that they need. So that it's definitely an ongoing challenge. And this has really made me focus the fact that we need to separate, the prenatal screening from the newborn screening, from kind of, young, rare family kind of diagnostics. The good news is across all of them, there's a lot of exciting things that are going on. And I also want to thank Dean too for raising, the cost issue, because the whole how health systems, value and a particular treatment, how we as companies price them. I mean, these are real things that we can't shy away from that have real impacts for the public health system. So, we're committed to doing that together. And that's why really at the end of the day, the paper called for engagement, for community engagement, because these are big, enormous issues that we're going to need everybody's input on over time to try to make real change.
I think that's great. Megan, I'm gonna let's kick it to you and just for your comments here, and then I got something to say about something too here. But and I think you brought up a good point. You had the prenatal screening done, which is a totally separate thing from newborn screening. And I think that sometimes in education wise, people don't realize that. And with it. So what are your thoughts here as we're closing in on wrapping this up?
Yeah, I mean, I think Dean made a really good point about, the follow-on care, right? After a diagnosis, like what happens next? And I think that's a really important conversation that needs to continue to happen, how these families are navigating the system and getting the education they need. So there's not enough things we can say about the importance of that, and just in total agreement that people need to understand what's happening to their own bodies and what's happening to their kiddos and how to make the best use of that information with good medical guidance.
Yeah, and I think part of the Rare 72 process that we're looking at is that, you both bring up that point, and we've identified that, is that there's going to be dots that have to be connected. We want to show that. And if you want to, we don't want to silo stuff, but you do have to reach a point where it's kind of like this bullseye, and you got the center core of what you're really after. And then when you start talking about the treatments, you've identified this thing on the screening, but that dot may reside on that very edge of the fringe of that bullseye. Now you're moving into a different target, and that is the treatment plans, which offers itself a whole set of challenges. A lot of them are geographical, some of them are cost, with that. So I really have liked the discussion that's happened here today. I want to ask if anyone else has any questions that are out here. Now would be a time if you want to ask. If not, I don't see anything else in the chat here this morning. I think we've identified some really good stuff to begin to build off of here. Chris and Megan, it has been just such a pure pleasure to have you and to talk about this particular topic. And Chris, I really was encouraged, because when you look at this, you can see how overwhelming that it can be. But I did like what you said. So, well, there's 4 million births in the U.S., but there's bigger things that we have tackled. So there's hope. There's hope that this can be addressed. This can be worked on. We can get a good system in place for the entire country. So thank you for your input there. And Megan, your relationship that you have working directly with the patients has just been awesome for this. So thank you. And I want to thank Trevere and Orchard for their input, and everybody who participated in this. Thank you all so much.
Our pleasure, Jeff. Thanks for everything you and Eden are doing, and for everybody who took the time to watch this. Reach out anytime, chris.porter@trevere.com. Happy to talk with anybody.
Yeah, thank you guys so much. It was fun actually being here today and talking about all of this. So anytime we can help, let us know. Thank you.
All right, thank you all.